So we're back now with three more great projects, and we're now going to hear from Healthy San Francisco, and presenting for Healthy San Francisco is Dr. Haley Hammer, who is the Medical Director of Family Health Center and Urgent Care for San Francisco General. And we're also going to hear from Tangerine Brigham, who is the Deputy Director of Health for San Francisco Department of Public Health, and also Director of Healthy San Francisco. So I guess, Tangerine, we're going to start with you, but welcome both of you. Thank you for making the long trip out here.
Well, thank you. Thank you for this opportunity to present on the Healthy San Francisco program. There are 60,000 to 70,000 uninsured adults in the city and county of San Francisco. In 2006, San Francisco adopted the landmark Healthcare Security Ordinance. The ordinance created two innovative programs, the Employer Spending Requirement and Healthy San Francisco. And this was done under the leadership of the mayor, the Board of Supervisors, the Director of Health, and through a broad-based community-wide planning effort. Healthy San Francisco provides uninsured adults with comprehensive, affordable health care, irrespective of their employment status, immigration status, or pre-existing medical conditions. For the city, Healthy San Francisco is a paradigm shift. The realization that San Francisco as a community could expand and improve access to care without providing the uninsured with insurance. Healthy San Francisco is a health access program, not a health insurance product. Our other distinctive features of Healthy San Francisco are that it capitalizes on the existing and varied array of providers. It partners with a local health plan, and it introduces new technologies that benefit both clients and also providers. Finally, Healthy San Francisco is based on an overriding principle of shared financial responsibility, from government to participants to providers. Healthy San Francisco's companion program, the Employer Spending Requirement, is a local mandate requiring employers to make healthcare expenditures on behalf of their employees. Independent research has found that to date, San Francisco employers have not appreciably reduced employment or wages as a result of this requirement. Healthy San Francisco has resulted in significant improvements in expanding health access and health outcomes, and I'll now turn it over to Dr. Haley Hammer to describe some of our successes.
Thank you. It's such a pleasure being with you today. Healthy San Francisco strives to expand access to care, promote appropriate utilization of services, and ensure patient satisfaction. I'll start with access to care. In each year since it began, Healthy San Francisco has increased the number of uninsured enrollees in the program. 4 years after its launch, 85% of San Francisco's uninsured adults, or 54,000 people, have voluntarily enrolled in the program. We also measure access by the number of providers and medical homes. Those have increased each year, and all the nonprofit hospitals in the city now participate in the program. I oversee the largest public health clinic serving Healthy San Francisco enrollees, the Family Health Center at San Francisco General Hospital and Trauma Center. One critical reform with Healthy San Francisco was to require participants to select a primary care medical home. Primary care in a medical home is fundamental to improving health outcomes and integrating healthcare delivery. Healthy San Francisco covers routine health screening, immunizations, and preventive care aimed at lifestyle modifications. Enrollees also have access to the full range of specialty and diagnostic services associated with their medical home. This reform has increased patient and provider satisfaction, changed how participants use services, and enabled patients to establish care with a primary care provider. An independent program evaluation found that more than 85% of enrollees remain enrolled. 80% of enrollees received a primary care outpatient service. Participants showed steadily decreasing ED use over time, and participant satisfaction rate with the program is 94%. The program impacts the lives of patients on a daily basis. For example, unbeknownst to Healthy San Francisco, this fall, a participant went on the air at our local public radio station, KQED, and provided her perspective on the program. She describes the loss of employer-based health insurance, the rising cost of healthcare premiums, developing a chronic illness, and finally enrolling in Healthy San Francisco. She ends her perspective with, while it's not technically insurance, for me, Healthy San Francisco works. My medical home is just blocks from my apartment, and the services are effective even for a complicated, misunderstood condition like mine. Healthy San Francisco, you make me so proud. I'm proud to say that I'm proud that I can say from firsthand experience that her story is not an unusual one. Healthy San Francisco is a model that works, and Ms. Brigham will describe how it can and has been transferred to other communities.
While Healthy San Francisco was not born out of crisis, it was born out of inpatience, and inpatience that localities across the nation face daily. A rising number of uninsured, diminishing financial resources, and insufficient data to determine if the local investment is having its intended results. Healthy San Francisco represents improved patient experience, improved quality of care, and more cost-effective care. The model is not bound by San Francisco's 49 square miles. The Department of Public Health has met with local leaders from various communities and provided technical assistance in those communities exploring the model. Aspects of the Healthy San Francisco model have been replicated. Howard County, Maryland has a Healthy Howard access plan that is structured similarly to Healthy San Francisco. Replication does not require a local ordinance. It requires political will, public-private partnership, and a willingness to examine delivery systems and medical strategies and financial strategies and opportunities. We are happy to answer any questions you might have.
Questions? Yeah, Carl.
Yes. I have two quick questions. First, let me just say I congratulate you on this program. It's very innovative, and particularly thrilled to see how many people you cover who would not be covered even under expanded national health care. First, have you detected any shift among employers from insurance or from health savings accounts to ESRs or any other shifts among how employers pay for their employees' health insurance? And second, related question, I know that you've had a significant impact on emergency room visits, and I'm wondering if you've done any cost-benefit analysis on savings to the healthcare system as a result.
With respect to the first question, the employer spending requirement on an annual basis, there's a report that's done by our Office of Labor Standards and Enforcement. In general, the shift between insurance, Healthy San Francisco as an offering, and the health savings requirement, there has been steady participation with respect to Healthy San Francisco. The shift has really been between insurance and the health savings option. The health savings option has increased as a percentage of employers selecting that, where there has been a decrease in the number of employers offering health insurance. However, health insurance remains the majority option for most employers. Over 80% of employers offer insurance in order to meet the mandate. In terms of being able to do a cost-benefit analysis of looking at the savings from a reduction in emergency department utilization, we have not done that yet. It will be probably the second component of a more rigorous evaluation for Healthy San Francisco. What we do know, however, is that the average per participant per cost has decreased over the 4 years as we've increased the number of individuals, and we believe that's directly due to the fact that individuals are receiving their care more cost effectively in a primary care setting as opposed to a high-cost urgent care setting or emergency department setting.
The ESR, the fee that businesses have to pay, I know that, was it the restaurant business that sued originally?
That's correct.
Has there been any other pushback? Have businesses left San Francisco? Has there been any negative fallout because of that?
There was a separate evaluation done by researchers from Dartmouth, UC Berkeley, and University of Massachusetts at Amherst, looking at this very issue. What they have found, at least to date, is that there has not been an appreciable reduction in employment and or wages as a result of the employer spending requirement. I think it's important to recognize that San Francisco does have a minimum wage. It is actually the highest in California, and therefore for those employers that are employing minimum wage employees, there isn't an option to make a reduction in their wages as a result of this. So we have not seen any reduction in employment as with respect to it.
How do you think that the speaking as a mayor who really pushed on the demand side, but as the governor knows, Kathleen knows, didn't really do enough, much as I tried on the supply side, you know, with the DCO thing with the hospital and everything. You know, I got to tell you, I really applaud what you all have done here. But how do you think this wears with time passing and the implementation, whether we like it or not, of the Affordable Health Care Act?
I think that San Francisco's effort is still important, irrespective of the outcome of the Affordable Care Act, which will now be heard before the Supreme Court. And that's because there are so many individuals who will remain uninsured, even with full implementation of the Affordable Care Act. Those individuals are cared for by local providers, public providers, nonprofit providers, for-profit providers. Those individuals are not going anywhere. And it will be the responsibility of those local entities to try to determine how to effectively provide care to them, particularly with diminishing resources, because the resources that are currently being cared for or being used to care for the uninsured, many of them might be diverted to actually expand health insurance at the statewide level. And we think that's important, but we think with diminished resources, it's really important for localities to look at creative, cost-effective ways to serve a continued and potentially growing population of uninsured.
And not to put words in your mouth, you still have the need for primary care, preventative care. And maybe I missed this.
You can put words in my mouth, yes.
Exactly, yeah, maybe I missed this in the materials, but can you give me some example? I mean, do you have data that show really the improvement because you're now, improvement in outcomes because you are now focusing not just on supply, but better supply, if you will? You know, families have medical homes, they're not waiting until they're ready to die to see a doctor, that kind of thing.
As Tangerine mentioned, we still have to do a more rigorous analysis of the clinical outcomes because, you know, the problem with comparing the clinical data before Healthy San Francisco and now is that we didn't even know really who all of our uninsured patients were throughout the city. So
that's going to take some time to figure
right.
that out. Yeah.
But we've certainly seen that the clinical outcomes that we do track, not just ED use, but hospitalizations, chronic illness indicators like diabetes care, as well as preventive health measures like immunizations, are improving. We have quality improvement programs throughout that extend to all the medical homes in the network, and it's been really exciting to see those improve as patients are much more located, much more associating their medical home as their place of care, not an urgent care center and emergency department.
Okay. Other questions?
Has the payment provisions been pretty much accepted by now? I mean, I know you had the Restaurant Association suit and so forth, but how about the rest of the community? Is there a general agreement that this is a fair system?
I think that, well, let me just first say that restaurants were the only group of employers that publicized the increased cost of the employer spending requirement. And the response overwhelmingly from patrons was, I'm fine paying another $1.50 or $2 if I know that it's actually going towards health benefits for my employees. So what we have found is certainly in the beginning, I think there's change, there's throwing your hands up in the air, there's, you know, even in places liberal as San Francisco, what are you talking about? But I think that because everyone has actually seen the benefits, we have put out significant data on our website showing enrollment, showing utilization of services, showing the use of those dollars. We have not had in several years since we've implemented the initial cries of concern with respect to this particular provision.
Thank you.
Yeah, David.
Yeah, one last question. When you pay the providers, the medical homes, the hospitals, et cetera, are you using a fee-for-service model or a global payments model?
A global payment model, and it's actually based on enrollment. So it's based on the number of individuals that have selected that medical home. So the medical homes themselves have an incentive to ensure that their care is appropriate and timely because people will select based on that.
I heard that when Massachusetts did its Health Care Act, one of the challenges that they found, one of the expenses that they hadn't anticipated was the mental health issues of so many behavioral drug addiction, alcohol addiction, and mental health. And I didn't know if that happened to you as well, and what you did about it, or what you are doing about it.
Right. So Healthy San Francisco does include behavioral health, both mental health and substance abuse. San Francisco actually, per capita of all 58 counties in California, spends more per capita on mental health than any other community, and we're less than 800,000. So we have a extensive mental health delivery system and financing for that. We did not have that as a significant cost increase. I will tell you our cost increase really was on the pharmaceutical side. When you were really dealing with individuals who have chronic conditions, it's really important to make sure in addition to their primary care that they also have access to their appropriate medication. So that was an area in which we had to increase our budget to accommodate that.
Thank you.
Thank you,
That was
guys.
very,
Appreciate
very
it.
good.
Great
Thank
job.
you so much.